Hello, welcome to OSE Immunotherapeutics Key Opinion Leader webinar. Today we have the pleasure of catching up with two leading providers from different geographies. We will also allocate some time at the end for Q&A, so feel free to tee up your question in the chat during the presentation. First, let me introduce Dr. Stephen Liu, medical oncologist from Georgetown University. He'll kick things off and discuss the unmet medical need as well as the overall therapeutic landscape in lung cancer. And then we also have Professor Benjamin Besse, medical oncologist, director of clinical research at the Gustave Roussy Institute in France. He'll present the Artemis study and registration phase 3 clinical trial at Tedopi in non-small cell lung cancer. Before we proceed, I thought it would be nice if we could have Nicolas Portier, PhD, CEO of OSE, briefly recap the company's ongoing efforts in addressing lung cancer. Nicolas, you have the floor.
Thank you. So good afternoon or good evening, everyone. Thank you for joining us in this webinar. So I will first briefly introduce the company and then enter into more details in the mechanism of actions of our therapeutic cancer vaccines before leaving the floor to Professor Besse and Professor Liu. So OSE Immunotherapeutics is a clinical stage biotech. We developed exclusively first-in-class immunotherapies. We're developing these innovations thanks to our innovative R&D engine and collaboration with European and US academics university. Currently, we develop 5 clinical assets from phase 1 to phase 3 in both oncology and in immuno-inflammations, either alone through properties or in partnership with some key industrial partners like AbbVie in the field of inflammations, Boehringer Ingelheim in the field of oncology or metabolic and cardiovascular disease, as well as Villejuif in the field of transplantation. So our most advanced assets is Tedopi. As you can see on our pipeline, Tedopi is a neoepitope, engineered neoepitope T-cell cancer vaccines. We will see with Professor Besse key data we have generated and published last year in the monotherapy in a randomized phase 3 trial in NSCLC in third line, and the study design of our next pivotal study in second line, still in monotherapy after failure to checkpoints in non-small cell lung cancers. And we will review also very briefly how we explore potential of combination of this new drug modality with either chemotherapy or anti-PD-1s in pancreatic cancer, in ovarian cancer, or in NSCLC as well. So if we enter now in the drug, in the assets Tedopi. So Tedopi is a combination of 9 optimized and engineered T-cell epitopes from 5 different tumor-associated antigens. They are emulsified with a ready-to-use formulations injected subcutaneously in patients, in the arm of patients, and then they will be captured and present by our antigen-presenting cells to educate our immune system, generate T lymphocytes, expand the pool of fresh T lymphocytes capable to recognize these tumor antigens. We have the capacity with the technology I will present to break immune tolerance against these tumor antigens by engineering this T-cell epitope. And then we have demonstrated that T-cell eliciting periphery has the capacity to migrate in tissue, in particular in the lung, when they can exert their functions, their cytotoxic function, elimination of cancer cells. So we have currently an orphan drug designations of these vaccines, thanks to the engineering of the technology for the HLA-A2 molecule. So HLA-A2 was the HLA system in the antigens machinery presentations in humans. There is some polymorphisms, and the HLA-A2 is the most prevalent one, 45% of the populations, and we are now selecting these patients thanks to companion diagnostic biomarkers. So if we look now at the revival interest in the field of cancer vaccine, therapeutic cancer vaccines, there is 2 different approaches with 2 different clinical positioning. On one side, on the left, the off-the-shelf precision medicine approach that we are developing. On the right, the personalized approach in the field of neoantigens, which require to have access to tumor biopsy, sequence the genome of the patient, sequence the genome of the tumor, identified and predict the key T-cell epitopes in these mutated neoantigens and manufactures for each patient an individual vaccine. So it needs time, it's costly. Unfortunately, there is some variability in the predictions of T-cell neoepitopes and hence the immunogenicity generated in patients. But these last 2 years, we have seen very promising data in the early settings adjuvant approach to prevent tumor relapse after surgery in combinations in non-randomized phase 1 and phase 2. And so we think that it's a really interesting approach to move forward. If we come back to the off-the-shelf precision medicine approach, we have a ready-to-use vaccine. We have a ready-to-use emulsions, and we can select the patients with a companion diagnostic, not based on the tumor antigen expression, but based on the HLA genotype of the patients, just by a blood sampling. And then we have demonstrated, I will show you some data, that this approach generates strong CD8 T-cell response in patients. And we were capable to demonstrate positive data in a randomized phase 3 in the metastatic disease settings, how we can extend survival for these patients as compared to chemotherapy. So 2 different approaches with very interesting positioning in terms of clinical development. One key element in the field of therapeutic vaccine now is based on the cancer antigen immunogenicity. So a good therapeutic cancer vaccine needs to have tumor-specific antigens for sure, but also very strong antigen immunogenicity. So what we have done, or the technology of Tedopi, is based on identifications and the identification of validated T-cell neoepitopes in the lab from different and shared tumor-associated antigens that have been engineered to break the tolerance, increase their foreignness, and increasing the immunogenicity very close to pathogenic antigens by engineering the affinity for the TCR or the HLA, the machinery which is capable to present or recognize these tumor antigens. This is just a summary of the process that have been performed in the lab more than 10 years ago. So thanks to the understanding of the key residue at the interface in a T-cell epitope peptide, at the interface with the MHC or the TCR, a series of thousands and thousands of different peptides and T-cell epitopes from 5 different tumor-associated antigens. I was explaining that we screened thousands and thousands of different T-cell epitopes from 5 different tumor-associated antigens, from P53, CR to MH2, MH3. And then the stronger epitope for their affinity for the TCR HLA have been selected. And you have an illustration on the right part of the slide showing that a wild-type epitope in blue, T-cell epitope from a tumor-associated antigen, can elicit some level of immunity, not so strong as the T-cell have weak cytotoxic functions. Just by engineering the epitope, we can dramatically increase both immunogenicity and cytotoxic profile of the tumor-specific elicited T cells, cross-reacting with tumor cells expressing the wild-type antigen. So several of these epitopes have been screened in the lab, in vivo in animals, and then the combination of the best 10 neoepitopes have been selected in terms of synergy and move forward under clinical development. So this is just some data from our phase 1 and phase 2 studies where we explored, of course, the safety of this approach, but also the immunogenicity. You can see on the left some immunogenicity elements measured by tetramer response by flow cytometry in cancer patients, very advanced settings, where we can see that epitopes that have been engineered for the TCR affinity in green or HLA affinity in red, both are highly immunogenic in patients and do strong tetramer positive response against the peptides that have been used for vaccination, but also for the wild type corresponding antigens expressed by the tumor cells, validating the concept that TCR cross-reactivity is key. We can engineer epitope to break tolerance and induce T cells that cross-react with the tumor antigens. On the right, this is the individual data for each individual peptide during the phase 2 in non-small cell lung cancer patients, where we can see very robust and very broad T-cell immune response in the majority of patients against individual peptides, either the wild type, the epitope modified for the HLA or for the TCR. And I will just stop after this slide, just illustrating or reminding some data, key data we generated in phase 2 in NSCLC patients, more than 60 patients, stage 3 and 4, post-chemotherapy, where we observe very intriguing survival, long-term survival rates in these patients at that time, post-chemotherapy. And most importantly, we found a strong correlation between immunogenicity measured in the blood, ELISpot response, and survival, significant correlation between survival and immunogenicity. So I'm done for my presentation. Thank you very much.
Great. Thank you, Nicolas. Apologies for the slight technical difficulty, but let's transition to our first KOL speaker, Stephen Liu. As I briefly mentioned earlier, he is the Associate Professor of Georgetown University's Lombardi Comprehensive Cancer Center. He has extensive training starting at Johns Hopkins University and then the University of Southern California, and he focuses on innovative treatments for lung cancer and related malignancies. He leads the thoracic oncology efforts and the phase 1 development therapeutic group, and he's been published in numerous recognized journals, including the New England Journal of Medicine, Journal of Clinical Oncology, Journal of Thoracic Oncology, Lancet Oncology, and Cancer Discovery and Clinical Cancer Research. Without further ado, Dr. Liu, the floor.
Thank you, Sue. I want to talk a bit about non-small cell lung cancer. Professor Besse and I both focus on this subtype. And, in our lifetime, we've seen a dramatic shift in not just how we manage lung cancer, but really how we perceive the disease. It's happened in a relatively short period of time. And coming from the US, when we think of lung cancer is by far the leading cause of cancer-related death in the US. Shown here are estimates for 2024, and you see for both men and women, the leading cause of cancer death, outnumbering breast cancer and prostate cancer combined. That peaked in the late 90s, early 2000s, and while we have seen progress due to some innovative new paradigms, still far and away the leading cause of death for both men and women. In the 80s, 90s, even the early 2000s, lung cancer was known for a tremendous and profound sense of nihilism, and many community oncologists, which is where most lung cancer care is delivered in the US, really weren't deciding between which treatment to give, but whether to give treatment at all. As recently as 25 years ago, we were still publishing analyses comparing treatment to placebo in the frontline setting to best supportive care, because at that time, our drugs did not work very well. They were fairly toxic and often the treatment worse than the disease. We've come a long way in disrupting that sense of nihilism with some important advances. And with platinum doublet chemotherapy, better supportive care, chemotherapy did become our standard of care. I showed this study, ECOG 1594. This was a study, a cooperative group study in the US that compared the 4 main chemotherapy doublets in use at the time. It showed that they were all roughly equivalent, but I showed this to show how limited the outcomes are with chemotherapy alone. If we look at the left in progression-free survival, we see the median progression-free survival somewhere around 3 months or so, meaning that when we start treatment by month 3 and month 4, most patients have seen their cancer start to grow. The benefit of chemotherapy really is a transient one. If we look at survival on the right, a median survival well under 10 months, by the time we get out to 2-3 years, we see that survival number very close to 0. Chemotherapy alone is of benefit, improves quality of life, extends survival, but there's a very low ceiling as to what chemotherapy can accomplish. This was our standard for many decades. We didn't think we could do much better than that, and it really did plateau. It changed with the integration of immunotherapy. Immunotherapy changes the paradigm in a dramatic fashion, very quickly replacing docetaxel as second-line therapy. It has since emerged as part of our standard frontline treatment, either alone, in combination with other checkpoint inhibitors, or in combination with chemotherapy. Now, in 2024, our standard after chemoradiation, before surgery, after surgery, or both. Immunotherapy really weaved into our paradigm at every step of the way. And the advantage of immunotherapy is clear. It has generated tremendous enthusiasm from both scientific and lay press, and justly so. It is the durability of response, the potential for long-term survival, maybe even cure. And on top of that, a much more favorable safety profile. If we look at the study that really changed our paradigm in 2016, we saw Keynote 24, and shown here are the 5-year survival updates. This was for patients with high PD-L1 expression, which is about 1/3 of our patients with non-small cell lung cancer. Receiving pembrolizumab alone on that blue bar, we see 30% alive at 5 years, 1 in 3, something we could not fathom just a decade ago. In addition, if you look at that blue curve, you get the sense that it flattens out, that there is a tail, a plateau, suggesting that if you're alive at 4 years, very likely to be alive at 5, 6, 7, and hopefully beyond are these patients that we are potentially curing. Now, this is a very elite population, but we've seen in real-world analyses, this work done with Dr. Solange Peters and myself, showing that in very large data sets across all PD-L1 strata, about 20% of patients are surviving to 4 years in the real world with all the comorbidities and constraints that population entails. This is real. Patients are surviving. Patients that would not be alive with standard therapy are alive now. And just a few days ago, we saw the update from Checkmate 9LA. This was our most aggressive regimen, 4 drugs, nivolumab, ipilimumab, plus 2 chemotherapy agents. And we see here 18% of patients alive at 5 years. Now, while we often celebrate this 1 in 5 alive at 5 years, if we flip that curve around, it means about 80% of people are not alive at 5 years. Our goals here are to extend that survival for people that are responding, but really to get that type of quality, durable response for more patients, for all of our patients. That is our goal, and we've taken a very important first step. I think it's clear that we have a long way to go. The unmet needs for lung cancer, we know that a small subset will achieve that long-term survival. The vast majority will not. And after chemoimmunotherapy in 2024, our standard is docetaxel-based treatment. Shown on the right are the outcomes from the REVEL study, looking at docetaxel plus ramucirumab. Now, those curves fairly close together. The adoption of ramucirumab, very inconsistent given its modest benefit. But overall, in this setting, we see a response rate of 14 to 23%. Most patients not getting a response. The median progression-free survival, 3 to 4 months. The median overall survival, only 9 to 10 months. This was published 10 years ago, and we're embarrassed to say this remains our standard now. We've tried to do better, and there have been a number of phase 3 studies looking to improve upon docetaxel. This seems like a low bar, but one we have not been able to clear. Small sampling here of very highly publicized and highly touted phase 3 trials that failed to improve survival over docetaxel. Canopy 2, looking at an IL-1 antibody, canakinumab, no difference in overall survival. The Contact 1 study in the Sapphire trial, looking at VEGF and multikinase inhibitors, cabozantinib, sitravatinib, no difference in survival. The Evoke 1 presented a week ago today, looking at the TROP2 antibody drug conjugate sacituzumab govitecan, no difference in survival. By press release, the Carmen LCO3 tusimidumab raftansine will be presented later this year, but we know no difference in survival. What do these have in common? These were built on solid science, led by very esteemed investigators. And what these combinations showed was an improvement in outcomes, better response rates, better progression-free survival in smaller studies, very promising. But when put to the test of overall survival, they did not improve survival. People didn't live longer. And if we look a little more closely at the Evoke 1 trial, again, this very disappointing phase 3 trial, we saw there was no improvement of this ADC over docetaxel. But again, look at a modern day rendering of docetaxel and how it's performing. 18% of patients responding, meaning 80% plus not responding. A median progression-free survival of 4 months, a survival of less than 10 months. And what is perhaps most vexing with docetaxel is it is a very difficult medicine to give. 40% of patients, nearly, with a dose reduction, 14% stopping therapy just due to toxicity. The median duration of exposure, only 2.3 months. The median time to deterioration based on quality of life, 2.1 months. I can tell you, it is very hard to have numbers that are worse than that. People are voting with their feet. This is a real-world analysis of U.S. practice patterns published by Dr. Fabrice Barlesi and myself, looking at real-world treatment sequences after chemotherapy and immunotherapy. If you look at that blue bar at the top middle, we see non-platinum-based chemotherapy represents less than 30%. This is our only standard in the U.S. And when we are free to choose what we like, we do not choose docetaxel. Even though this is our standard of care, simply a medicine that we do not like to give, patients do not like to receive. What doesn't show up on our toxicity tables is the deterioration, is the overwhelming fatigue, and the low overall quality of life. Really choosing between this treatment and no treatment, often patients and providers choose no therapy. When we look at our current status in lung cancer, the use of immunotherapy has changed not just our standard of care or our treatment algorithms, it's changed what's possible, but along the way, it has raised our expectations, and we are no longer satisfied with regimens that offer modest response and transient benefit. What we want is long-term benefit. What we want is survival. In addition, we also want tolerability to maintain that high quality of life, and the toxicity of docetaxel prevents it from being used. It is our standard of care in phase 3 trials. It is not our standard in clinic. People choose to offer anything else. And when we look back at the practice patterns, we see about 30% of patients receiving a checkpoint inhibitor, second line, after progressing on a first-line checkpoint inhibitor. There is no data that this is of any benefit, but we choose that because of the prospect, the minute hope that we can offer long-term survival without overwhelming toxicity. I think that speaks volumes for what we need in lung cancer. Most patients don't achieve durable benefit. What we need is safe and effective treatment for those patients that give us at least the prospect of something better and long-term. And with that, I'll turn things back over to Sue.
Great. We really appreciate your effort in this challenging area, Dr. Liu. Next, we have Professor Benjamin Besse. He's a recognized medical oncologist specializing in thoracic cancer, currently serving as the Director of Research of Clinique Gustave Roussy. With expertise in personalized treatment approaches and early drug development, he has authored over 250 peer-reviewed articles and has led numerous clinical trials. Besse holds leadership roles in prominent scientific councils and networks, including chair of the EORTC Scientific Chairs Council and coordinator of RHYTHMIC, the French network for malignant thymic tumors. Professor Besse, I'll hand it over to you.
Thank you very much. So Stephen perfectly set up the challenge we have in second line treatment after chemoimmunotherapy in non-small cell lung cancer. And this is where the cancer vaccine Tedopi or OSE 2101 was developed. And I will briefly review the data we have generated. So as Stephen said, upfront, when you diagnose a patient with a metastatic non-small cell lung cancer, you have to look at the targets. And we know that the Caucasian population, probably 15 to 20 of these patients have a target that will change their standard of care, that will receive first-line targeted therapy. But for 80% of the patients, it will be immunotherapy or chemoimmunotherapy. And the main unmet need today is, as Stephen said, the second-line treatment. I've just summarized some studies that Stephen have already presented. On the left side, one strategy that is to give immunotherapy plus VEGFR inhibitor, and it's totally negative against docetaxel second line. And at the right side, the very, very disappointing curves of this new family of drug, the antibody drug conjugate, in which 2 years ago, a lot said this will be the new standard of care second line, while the figures are not good enough to make it a standard of care, and we are still using docetaxel. And it highlights the need for alternative strategy to ADCs or oral drug. Tedopi has been tested against docetaxel in a randomized phase 3 trial called Atlante 1. We enroll patients with HLA-A2 positive profile. What is HLA-A2? It's like your type of blood, A, AB, O, your blood type. It's a different type of immune system. It's not good, it's not bad to be HLA-A2 positive or negative. Roughly half of the Caucasian are HLA-A2 positive. It's only those patients that can process the vaccine and then develop a reaction against the vaccine and the cancer cells. So we enrolled patients that were pre-treated with chemotherapy and immunotherapy. At the time this trial started, it was not a standard of care to this combination of chemo and immunotherapy. So some get first chemotherapy and other chemotherapy followed by immunotherapy, and other the combination of two. Brain mets were allowed but controlled, and there was a 2-to-1 randomization between Tedopi, subcute, or docetaxel or pemetrexed. It was one or the two chemotherapy that was allowed. And the secondary endpoint was OS. The trial started before the pandemic. So we aim to enroll 323 patients, but because of the COVID time and the vaccination against COVID that was a bit counterintuitive with the vaccination with Tedopi, we decided to stop the study. And as you can see, only 219 patients was enrolled in the study. Of interest, an analysis of this population showed that only the patients with secondary resistance to immunotherapy derived a good benefit from the vaccine compared to the chemotherapy. It means that these patients with at least 6 months of immunotherapy were more likely to benefit from the vaccine. As if I was responding to an immunotherapy, I will respond to the vaccine. If we look at the subgroup of patients with secondary resistance, you can see the overall survival goes from 7.5 months with docetaxel to 11.1 months with Tedopi, with an average ratio of 0.59, which is quite strong because lower than 0.6. So there is really here a signal of efficacy. If we look at the different subgroup, maybe the patients with brain metastasis had no real benefit from the vaccine, although it's a very small subgroup. But you can see that most of the patients, whatever their stage, their smoking status, had a benefit to the vaccine. The good part also is the vaccine is the side effects that are lighter than for docetaxel. So the time for the worsening ECOG PS2, which is the time from the start of the treatment to, let's say, an EV chronic fatigue and the fact that you are not able anymore to live your daily life, this period is extended with the vaccine. It has two causes. First of all, the vaccine is much more tolerated than the chemotherapy. If you look at the severe side effect related to the study drug, it's 3 times more severe side effect with the chemotherapy compared to the vaccine. And on the right side, you have the quality of life that is better, but it's obvious if you can control the disease and then decrease the side effect of the treatment, obviously the quality of life will be better. It's only a subgroup of a study that was stopped for recruitment, so it's a signal of efficacy that we have to confirm in a new randomized phase 3 study, and this is the Artemia study that I will present now. Before starting the study, OSE Immunotherapeutics met the FDA and agree on the population. So HLA-A2 positive non-small cell lung cancer with secondary resistance to immune checkpoint inhibitor. They agreed on the comparator, the docetaxel, which is still valid since the other drug didn't make it. They agreed on the primary endpoint, which is overall survival, really strong in that setting, the main secondary endpoint, in particular the quality of life of the patients and their reported outcomes, and a biomarker designed for the selection of HLA-A2 positive patients. So the trial has already started in the US and the recruitment is now open. The design is really similar to what we have seen with Atlante 1, which is a randomization 2-to-1 between Tedopi or docetaxel in roughly the same population, but restricted to the patients with secondary resistance to immunotherapy. So all these patients had the degree of benefit to their first immunotherapy. Obviously, HLA has to be positive, and all histology, squamous and non-squamous, are enrolled. There are other efforts with Tedopi in other in other type of disease, and this is the other cancer area where Tedopi is developed. There is an ongoing study of Tedopi combined with immunotherapy as a second-line treatment, post-chemoimmunotherapy. And there are 2 trials with maintenance Tedopi after standard of care, one that is currently recruiting in the ovarian cancer, and one that is close to recruitment in pancreatic cancer. And the readout is expected this year, although the readout for the 2 other trials is expected in 2025. And with that, I will give back the floor to Nicolas.
Thank you, Benjamin. So thank you all again for joining us today in this webinar. So we are really happy and really proud to develop one of the most therapeutic cancer vaccine in terms of clinical developments, an off-the-shelf cancer vaccine with what we think a very differentiated but complementary mechanism of actions after PD-1 failure. When the immune system is not strong enough to eliminate the cancer, we need to train new troops, form new fresh soldiers, and send a new wave of immune soldiers on the battlefield. So we are highly convinced, thanks to the data we have generated and published last year, that there is a place for cancer vaccines in these advanced metastatic settings. Patients need innovations. I think Professor Liu explained that we need to increase survival in these patients. We need to have drugs that are well tolerated for our patients. So we are eager to start this phase 3, this pivotal confirmatory phase 3 in second line in this population of secondary resistance or acquired resistance after PD-1 failure, and to hear more about the phase 2 exploratory studies in combinations to see whether there is broader potential in other indications, or when we combine this new drug modality with chemo or anti-PD-1s. Thank you very much to all for joining us today.
Thank you, Nicolas, and thank you, Professor Besse. We look forward to any updates on the Tedopi results. This concludes our prepared remarks, so we'll proceed to Q&A. I'll give a minute just so we can queue up some questions. As a reminder, you can ask questions by typing in the Q&A tab, which should be located on the right side of your screen. And here's one. I will read one off here. I think this is more for the KOLs. Could you share a brief overview of the current treatment landscape for non-small cell lung cancer, including success rates as well as the presence of various mutation influence choices of the treatment?
Yeah, so I can start with that. As Benjamin mentioned, we first subject these tumors to biomarker testing, and if we find an actionable target, like a mutation in EGFR, a fusion in ALK, then we go down the targeted pathway. The targeted agents work for nearly everyone. Profound, rapid, deep responses. They can work for quite some time, but they do not work forever. We do expect resistance. If we don't find one of those actionable alterations, which is still the majority of the time, then the standard treatment is immunotherapy. And we have a lot of different ways to deliver immunotherapy, either a PD-1 or PD-L1 inhibitor alone, with a CTLA-4 inhibitor, or with chemotherapy. And while we're waiting for results from direct head-to-head comparison, long-term results between all these strategies are, I think, pretty similar. A subset of patients with long-term survival, not the majority. And really, we need something better for those patients that don't achieve that. Benjamin, I'm not sure if you have a different approach.
No, I fully agree. The issue is that I would say all the active drug has been moved to first line, depleting the second line. I mean, 5 years ago, we used immunotherapy in second line, but it's so effective that it's now in first line. And it's true that this is really the space where we need improvement. And as we said, there were strong competitors in the field to Tedopi, in particular the ADCs. And in fact, there are, well, we realized, and I think we are all surprised, that docetaxel is a hard to treat standard of care, and we need an alternative option to this drug.
Yeah, no, that's really great. So we recognize that the non-small cell lung cancer treatment market, it's super competitive, both in terms of what's available and those in the pipeline. In your view, what sets Tedopi apart from the rest?
Well, the I would say the landscape in second line is not that competitive. Well, it's I would say is not anymore compared to 2 years ago. We will have other phase 3 trial with ADCs, and we're waiting for the readout. But the TROP2 ADCs were disappointing. There are attempts to use ATR inhibitor in second line. It's a kind of like PARP-like inhibitor, let's say, and there is a phase 3 ongoing. But the possible options that we see are quite limited, and Tedopi is quite unique in the way it can activate the immune system, and the fact that you are targeting a population that had a degree of sensitivity to immunotherapy makes sense. So the idea is really to reverse the secondary resistance to immunotherapy. So this is, well, we have promising data from the first study.
Yeah, I agree with that. I think that what I like about the agent is that it is, as Benjamin pointed out, very different. We're not relying on cytotoxics, which we know offer only a transient benefit. And while antibody drug conjugates have a different design, they exert their effect through cytotoxic means. And so I do think the ceiling is lower there. What sets Tedopi apart for me is really in the early signal was survival, not response rate or PFS. It was overall survival. And I think that there's no clear surrogate for it in this day and age. In addition, I think that one of the curves that Benjamin really pointed out that resonated with me was that sort of time to worsening performance status. And while some patients may derive benefit transiently to docetaxel, we can see others where you get the sense you're almost deteriorating things faster. Tedopi is much better tolerated, and by avoiding the toxicity of chemotherapy, I think we offer the prospects for a much more meaningful treatment.
Yeah, that's great. Maybe a quick follow-on to that, Nicolas. Maybe you could give a brief overview of how Tedopi works from a mechanistic perspective.
Yeah, as I think all cancer vaccines, we have two key properties, which is antigen selectivity, but most importantly, I think antigen immunogenicity. And there was a lot of effort, and there is still a lot of efforts to identify the best source of cancer antigens, mutated or not. But the difficulty is the immune tolerance. We need to have antigens, tumor antigens that are foreign enough in order to make sure that our immune system will see them, will recognize as strangers or foreign, and then amplify the immune response and then kill the tumors. So this is not something that is easy. We have succeeded in generating highly immunogenic cancer antigens epitope by engineering these epitopes and to use the intrinsic property of the immune system to be cross-reactive. There is not one T cells for one antigens. Our immune system is intrinsically cross-reactive against different pathogens, self-antigens, and cancer antigens. So we can design foreign antigens, engineer cancer antigens to increase their level of difference to the self, break the tolerance, and educate T cells, and then cross-reactivity with the tumor antigens and elimination of these cancer cells. That's the trick in our technology.
Yeah, that's great. So how about for the KOLs, I think this is more appropriate. We look forward to the following the progress of the confirmatory pivotal trial for Tedopi, especially after the encouraging results from the Atlante one. Could you recap any differences in terms of trial design focus between this and the phase 3 trial?
So the main difference is that we have restricted to the population with secondary resistance to immunotherapy. They have received at least 6 months of immunotherapy. And when you give a chemoimmunotherapy, for example, first line, usually you assess, well, you give chemo plus immunotherapy during 3 months, and roughly after you just give immunotherapy. And during the first 3 months, you don't really know who is the the good guy if it's immunotherapy, chemo, or both. But after 6 months, if the patient is still in response, it's probably the immunotherapy that maintained this response for a long time. So it's a very simple criteria, but quite solid, and it's an international criteria defined by the Immunotherapy Society, SITC. That's the main difference. We are a bit more restricting also on the brain mets because there is no signal affectivity there. So the patients must have, if they have brain mets, then they must be completely controlled.
Yeah, to me, it's just a natural sort of following the science and really where that signal was strongest and where it made sense. Because as Benjamin pointed out, the world is different now than it was when Atlante was conducted. So I think it's a natural continuation to really find, where this agent is going to provide the most benefit.
Right, that makes sense. Nicola, maybe you can help with this one. Can you provide some more details on how the companion diagnostic screening will be used as part of this trial protocol?
Yeah, it's a very easy test. So just a blood sampling, no need of tumor biopsy, tumor resections, just blood sampling, and then it's new next generation sequencing technologies just to identify what we call the genotype, so the allele that is expressed for the HLA gene. So if the patient is HLA-2, which, as explained by Benjamin, is roughly 45% of the Caucasian population. So patients will be selected just by this blood sampling. And why we select this HLA-2? Because the vaccine or the epitope have been engineered to increase affinity. And we know that HLA-2 patients are the biological responders to this vaccine. So we need to have patients that really biologically respond to the vaccine to make sure that at the end we may have a clinical benefit.
Yeah, and maybe another one for the KOLs. Tedopi certainly has promise in non-small cell lung cancer as a monotherapy. Could you comment on the potential synergies between the cancer vaccine with immunotherapy?
I think it's a very natural combination, and certainly you want to show benefit here, but the potential, the combinability, I think is quite vast. This is a drug that does not have sort of overwhelming toxicity. It can be combined very well, and most combinations that we use in lung cancer are additive. But I do think that in this particular instance, based on antigen presentation, there's the potential for true synergy. So one could certainly see a world where this is moved into different settings in combination. I'm not sure if Benjamin has a different perspective.
No, I fully agree. And the combination is part of the development of Tedopi yet, since there is this trial ongoing combining Tedopi plus an immunotherapy without a safety signal that would have stopped the study, which is a good sign. And there are also a study in ovarian cancer and combined with chemotherapy in pancreatic cancer. So yes, it makes complete sense to combine the treatment.
That's very good. And then for Nicola, following this, could you share some further details on the Tedopi potential in other cancers such as pancreatic cancer and maybe ovarian cancer?
So this is ongoing studies, so I would not be able to share any information for sure. So I think, as explained by Benjamin or Stephen, we have a very good safety profile, which is important if we want to combine with another molecules. Otherwise, you increase biological response, but also toxicity. And what is, I think, important also is complementarity in terms of MOA. So it's a very differentiated mechanism of actions, very different from the anti-PD-1s, very different from the chemo or the other drug modalities. So if we want to look for synergy, we need to have for sure differentiated mechanism of action. So that's really important. That's why we explore combination with anti-PD-1, how pushing on the gas pedal with the vaccine and raising the brake with anti-PD-1 can clearly unleash the anti-tumor immune response. But there is also rationale to combine with chemo, for example, in our pancreatic cancer study, where we need probably to slow down the rate of tumor growth in order to have time of our immune system, because the T cells need time to kill one cancer cells. But when you think that the patients are progressing, the number of tumor cells is growing, and so we need to probably reduce the rate of tumor growth in order to make more time for our immune system to eliminate these tumors.
So I think that's those are all our questions. I know you took the time to answer so many here. So thank you everyone for joining us here today. We appreciate it's been a really busy week with ASCO and the late hour in Europe for our audience. If you'd like more information on the company, please do not hesitate to access their website, oseimmuno.com, or research at edisongroup.com, OSE Immunotherapeutics. This recording will be shared in the next coming days. Thank you all.